Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Rich. How are you doing today?
Hey, I'm good. How are you?
I'm doing well. So Rich, today's podcast, we're talking about preparing for evacuation, whether that be really rotary wing or ground or submarine. Generally, they're the same except the environment. But if you wouldn't mind, since it's the first time on this podcast, would you please do a quick introduction of yourself?
Yeah, thanks for having me. My name is Rich. I'm a soft medic, and most of my career's revolved around flight medicine.
Oh, perfect. So just kicking into this, what exactly is your environment like? Like, what are some of the challenges that you face?
Yeah, so biggest thing when it comes to rotary wing medicine, you're dealing with the elements. So you lose a lot of your senses. You're unable to hear. You lose a little tactile feedback just from the vibrations, turbulence, but it's not too bad. Depending on climate control of the aircraft, it can get pretty cold with the wind. You are constantly kind of dealing with an airspace issue. So on the ground, you're kind of looking for enemy threats. In the air, you're looking for any, other aircraft, anything that could impact the aircraft. So yeah, your focus is on the patient, but it kind of never stops that airspace surveillance. Other stuff that you kind of have to deal with is kind of the cable management, your ICS cord that you talk to with the crew, tie down point. So it's a lot of just cables and ropes in a tight space where it's dark and loud.
All right, so that sounds pretty easy. So, obviously, over your time in service, there's going to be common mistakes that you see from medics on the ground handing over to you. Like, what are some of the common things that you've seen that you're just like, classic ground medic? Like, what normally do you see?
Yeah, so some of the stuff I notice more so in training, and I think it's a training scar when people try to cover up their casualties from rotor wash. Everyone's tendency is to just bury their chest into the patient's face, but the problem with that is, you got a plate carrier and some magazines there, so that can kind of hurt. So what I usually tell guys is maybe cup your hands around their face. If they have eyes and ears on, leave them on. If they don't have them, carry a cheap pair in the litter kits. But biggest thing is trying to protect that airway. Especially if they're intubated or criked, that it gets a little more important. An option for that is if you have a BVM, you can just stick it on the ET tube and just hold it there. And that will do pretty good to keep dust from just going into the dude's airway, making sure if somebody's got control of it, don't just let go of it.
Yeah.
Other things I've noticed is whenever people request equipment from aircraft that are inbound to an objective, if it's blood and an extra litter you need, try to do that ahead of time. And it goes big into planning. So if you can engage with those assets ahead of time and tell them, hey, we might be doing something tonight. If we call you guys, can I throw this litter and the spare aid bag on there and maybe a unit of blood, and we exchange that at handover? That is better than last minute on the deck you're asking, hey, I just gave you this guy, give me one of your units of blood. Like, there's no guarantee of that. And most guys may not give you their blood if that wasn't planned for. So, because that was planned for the patient and the transport.
Yep.
Documentation stuff. People seem to take the boldest Sharpie they can find and try to write small numbers with it. So a fine point Sharpie goes a long way, and just taking the extra second to make it legible, or training one of your guys to write it legible, it's good form factor. And one other thing I'll see is people tell me, let's say they did several bumps of ketamine, and at the handover, they're like, I gave a total of 500 milligrams of ketamine. It's like, okay, that's great. What was the last dose you pushed, and how much was it actually? So that will kind of cue the flight medic to, okay, I should prepare for a redose soon, or okay, I got a little bit of time to work with.
Would you prefer they dose them on the ground or let you do it?
If they can just do a quick bump right before, I think it's good technique, but it shouldn't be at the cost of having to rush through the handover. Because the worst thing you could do right when an aircraft is flying over is having the patient unsecured and open, just to push a little bit of ketamine. So it's one of those, you're weighing the risks. If you can do it quickly before the aircraft's inbound, sure. If it's at the cost of having the blanket fly open and dust is flying into the patient, you can just tell me when the last time you pushed it. So it depends.
Okay. So another thing, and I think as far as evacuations, they kind of come, I think, in two flavors. One being like a rapid evac, and another one where it's like a more extended care, kind of a critical care type transport type situation. Yeah. So I think the vast majority of guys at least are training for this rapid evac. So if you wouldn't mind kind of walking through this, like how important is it, like an accurate mist? So the reason why I say that is, way back in the day, like guys would have pre-planned mists like written up, and like the injury pattern wouldn't even match the patient, but it was something that would be concerning enough that would launch a bird. So, guys would just rattle off this mist and the patient would not even match, but it was kind of like they'll figure it out, en route. How important is that mist, and the accurate triage, like this is actually an urgent patient. I guess, from your aspect as a medic, maybe a slightly larger aspect as far as resource management, kind of what are the implications of that?
Yeah, so I'll start kind of outside in. So I'd say the mist is important. If you are, let's say you have a dust-off asset, but they're a shared asset among, the domain, the mist helps kind of to triage, like, okay, which guy needs it more? So pushing inaccurate miss is almost as bad as over prioritizing casualties when other guys might end up needing it on the battlefield. So it's not a benign thing. There are implications to it. Secondly, like the thing I cue into is the mechanism, whether this was a GSW or a blast or a fall, that already kind of preps like, okay, I kind of need to start prepping this equipment as opposed to that. So it's important. It does help, one, from a resource management standpoint, but also for the provider on board, they can already start to queue in and things are getting prepped.
Okay. Maybe, I guess on the resource management, like that's prepping, the medic himself. And I remember it's not being combat, but in our rotations as a student, I was on life flight one day and we got a call that, he had a victim, multiple gunshots in the street, police are en route. And it was like, oh my God, this is my day, right? I was trained for this. I've trained, 6 whole months for this. En route, okay? Like, hey, the police are on scene. They're controlling, the situation like it's safe to, land. And in my head, I'm envisioning, flying the door open, combat rolling out, holding back, protecting the patient while simultaneously doing march. And when we finally landed, you find out is the guy, got hit by a car on his moped. He broke his leg, and actually everything is fine. And EMS was already there, and they put on a traction splint poorly. And now we're, life flighting this guy out, which is drastically different. Obviously completely unprepared for something
Right.
like that, because my whole thought process was oriented towards, gunshot wounds, bleeding, hemorrhage control, etc. And it turned out to be just an orthopedic injury. But simultaneously, like, once that life flight is, sent on a mission for this, like, he's not being sent something else.
Yeah.
The airframe itself, the crew, they're all at risk. And, just calling somebody up to take him away, is not necessarily cool.
Yeah, it's one of those, like, they're definitely a force multiplier, like rotor wing on the battlefield. So committing towards a mission that you didn't really need it for, you're committing it. That's kind of what it is. You can't really take it back once you launch it. So you need to be sure that this is going. There's a lot of yield for this CASEVAC or medevac, and that it's not being that it couldn't have been used somewhere else for better yield.
Yeah. And just, on the tactical aspect of it as well, that's a giant target flying through the air. Everybody's going to take aim on it.
Yeah.
And if that gets wrecked, like, now your evac is out.
Yeah. Now you're kind of just like, that's it. You've now turned what could have been a 30-minute problem to a day's problem, because aircraft recovery it takes a while. It's not just pluck and go thing. Not to mention you have a mass cal on your hands now. So
Yeah.
with not really a solid plan out. So it's not good. There's always risk associated with launching aircraft into an objective. So it's not a benign thing of just have them come over and then take this dude off my hands. Like there's always risk associated. So understand there's always a give and take. Like good medicine doesn't necessarily mean good tactics, and vice versa. So
yeah, absolutely. I guess who has ultimate control of that? Would that be? It's not the medic. I'm pretty confident of that. I'm guessing the ground force commander. I imagine the pilots themselves are assessing the risk.
Yeah, it'll depend based on the system, but generally the ground force commander will have authority to call that aircraft in, and there's also authority nested at the dust off to say, okay, yeah, we'll take this mission, because ultimately they are also assuming the risk. So, right,
cool. You had mentioned earlier, requesting gear. I guess what would be a standard loadout, like for any mission you would have, what kind of gear other than like an aid bag?
Yeah, so usually, aid bag plus, most aircraft are going to be outfitted with electronics, monitor, suction, vent. I fly with an ultrasound, video scope, drug pump, things of that nature. So there are already things built in to optimize the patient for transport. So I hear it sometimes in refresher where guys will kind of just rattle off, I don't know, arbitrary things like he needs a monitor, he needs a vent, he needs a suction unit. I'm like, well, okay, cool. Like what? Okay, tell me what else he needs.
Right. So maybe would special equipment be something like hypertonic? Would that be a normal thing you would bring?
Yeah. Guys are always flying with hypertonic. So okay. The 9-line special equipment is a good starting point, because to me, special equipment is something needed to access the patient. So that's going to be like the cut and lift kit. Maybe they need a Sketco. Maybe it's rough terrain. So we can't just land, we might have to hoist down and grab the guy. So special equipment, in my eyes, is some sort of equipment needed to access and assess the patient.
Okay.
As far as medications go, like, yeah, I mean, I don't know any service or unit that's not flying with, things that wouldn't be covered in, T-Tri-C or the JTS. Like, yeah, everyone's flying with hypertonic, if not those silver saline bullets. So,
okay. I mean, yeah. I'm trying to think of something else. Like, obviously, I guess how much. Obviously, every unit's going to be different in what their SOP is, what they're bringing. Yeah. But obviously, you guys are bringing blood, and I'm guessing calcium and TXA and things like that. Yep.
Yeah. DCR is built in to these platforms. So the TXAs, the calciums, 2 to 4 units of blood, depending on who it is, sometimes more. If requesting special equipment, I'd say can also involve, hey, bring me that spare litter, bring me that spare unit of blood. But having planned that ahead of time, investing in your assets, so when you need it, on the worst day of your life, you can at least cash out on it. So,
right. Awesome. All right. We talked about documentation and, writing legibly, which can be a challenge for some people on a good day. Say, I've been working my butt off on this patient. I start hearing rotors and I realize, like, crap, I didn't document like anything. What would be like the bare minimum? I got like 30 seconds to write. What would be the bare minimum that you need to actually take control of this patient?
Yeah. Biggest thing, if you're going to write something down, it's the stuff I can't see. So drugs, ideally. If you had a choice between writing down what drugs, like the narcotics, if you tell me he's got TXA on, all right, I'll remember that. If you tell me 3 different narcotics that you pushed, all right, hopefully it's written down. It's going to be a little harder to kind of, remember. So as far as priorities of work go, yeah, drugs, stuff I can't see. And then from there, it's the life-threatening injury. What's killing this guy? And just putting an X down and just drawing it on that figure on the casualty card or whatever you have.
Okay.
I'm not opposed to patients getting written on in lieu of a document or in lieu of a casualty card. Best documentation is the one I have. So,
right. One thing I found super helpful, definitely for me and in the training environment as well, is having some kind of like an acronym of some kind to help you remember like what to say, because you have seconds to do this handover before everybody on the HLZ is dead. So, is there a standard handover acronym? Like, I've used MIST. Another one that I personally like is the SIT-D. So SIT-D stands for like stable, unstable. What injuries did they receive? What treatments I did? And like, here's the documentation, and we're done.
Yeah, I like the SIT-D. The MIST is nice for like a launch and an en route thing, but the SIT-D is nice when we're actually talking face to face. What we like to do is, hey, give me a thumbs up or thumbs down as you're telling me stable or unstable. Obviously, thumbs up for stable. Injuries, give me, if we're short on time, give me what's killing the guy. If you say, he has a GSW on his leg, but he has peppering on his arm, but he has a junctional wound that's killing him, just tell me that he has a severe junctional wound.
Right.
What I also like is having the medic handing off point and touch me where the patient is injured. So if he's shot in the leg, I want him to poke me in the leg, and as he's telling me, hey, GSW, right leg. Treatments, prioritizing that, really, I would say like life-saving interventions first. If you tell me he has like tourniquets and wrap and stuff, I'm going to find that. So I'm not as worried about it. It's nice to have, but not required. But a crike is a pretty significant thing. That's something I have to manage. An IO or an IV is nice to know, so I can go straight to that access. A junctional tourniquet is definitely something I'd like to know if it's been done.
Yeah.
And finger thors. And then, lastly, we're at drugs. If you've been able to, if we have seconds and you were able to just write everything down accurately with your drugs, hey, these are all the drugs given. Okay, I'll take it. Ideally, give me kind of a short synopsis of what's been given. Like, hey, 2 grams TXA, 1 gram calcium chloride. I gave this much ketamine. This was the last dose I gave and when.
Mm-hmm. Nice.
Yeah.
So, ideally, en route, I would be able to talk to you, and a lot of this stuff I can do, en route, just to help get you in the mindset of this is what's going on with the patient. This, you would already have a good idea of like, this is what's killing him. This is the things I've been doing. Now you've actually gotten on the ground, or you've come down on the cable. Like, hey, this is the stuff I did in the last 5 minutes. Goodbye.
Yeah. It works until it doesn't, because I've had times where things were misreported, like drug dosages or what drugs. So I still write it down. I take note of it, but I also take it with a grain of salt because, as you kind of mentioned in your vignette of expecting a multi-system gunshot wound guy, you get like a car crash guy. So I try not to fall into a bias. I still take note of it, and if it's accurate, if it's not, then okay, cool. Let's start over. What do you have? And I take the last information more so at heart. So the handover is what I'll trust more than what's been pushed over comms sometimes.
Okay. So, you get on the ground, we're talking, obviously, the medic, his adrenaline is pinging, right?
Yeah.
He's been through this ordeal. He's handing him off. He screams up and down, this guy needs blood. He needs whatever it is he says. You get him back into the bird. Do you just take him for his word and just do it? Or do you actually assess?
Yeah. So I'm going to assess the guy. My job is to trust that you've done everything you said, and then to assume that none of it's happened. So I'm going to do my own sweep initially, once in the aircraft. Really just rechecking stuff and doing my own March assessment. And now we have overlapping coverages of, medical care. But if you were on the ground and telling me, hey, dude, this guy needs a finger Thor, or this guy needs blood. Okay, cool. I'm already kind of forming in my mind, like, all right, everything I'm seeing is matching up with that. Yep, he looks like a DCR patient. Yeah. Okay, let's get blood running. So
okay, that makes sense.
Usually, that's pretty much what the first minutes look like. Now, if we're in a circumstance where that ground medic hops on, because the objective is, clean, and we can all just leave all at once, then we can just kind of do the handover as we're already taken off to save some time. In that case, sure. Then the ground medic can start prepping blood, and as I kind of do my own sweep. So we can save a little time like that if we find ourselves in a situation like that.
Yeah. How important is it to get access on the, on the ground versus waiting for the bird?
I would say important. Nothing gets easier in flight or on an aircraft. So the more access points that are already established on the ground, that's just time we're saving in the long run, because care doesn't stop once he's off target. Like, it's ongoing through this continuum of from the target in flight to the receiving facility and then on. So as much as you can get, the better. If the most you could get was an IO, all right, I'll take it. That's the best access I have in this moment, and then hopefully we can bridge that to something better.
Right. Like some of the securing methods as well, like the chest seals on literally anything and everything. Like, does that survive once handover is done?
Yeah, helicopters have this innate ability to make things disappear that were right next to you a second ago. So, yeah, securing stuff is important. If you have IV line, if you have IVs in, I think some of these kits come with these tiny little Tegaderm windows. Like, I get the big ones every time. You need to make sure that thing doesn't leave, because that's what's saving this guy's life. IV lines, that needs to be taped like around the arm. Chest tubes, yeah, secured as much as you can. If chest seals do it, then sure. And loose equipment, yeah, there's extenuating circumstances because the environment has a say in how fast we have to get off the objective. But ideally, if you have a fluid warmer or units of blood, either somebody is physically holding it or it's tucked in under the blanket. If you patient secured, the blanket's on top of them, and you put equipment on top of that patient's chest, it's going to go flying off or get caught in something else. So, yeah, ideally, no loose trash, no loose equipment, no loose cords, because it's going to find a way to get caught on something.
Yep, absolutely. As far as just rapid evacuation, is there anything else that is very common that we need to clean up our game?
Yeah, I don't push off life-saving interventions just because you're about to hand off a guy. There's a balance there. If you're like 10 seconds from the aircraft touching down, okay, maybe I don't do the finger Thor, and maybe I just give it to him and tell him, hey, this guy needs your finger Thor. Conversely, if you're like 5 minutes away from the aircraft showing up, don't just kind of sit there idling. Like, patient care doesn't stop. Like, just because you're prepping for evac doesn't mean like he doesn't need life-saving intervention. So there's a balance there. Yeah.
So ideally, from wherever the medics were doing their main treatment, whatever location, right? To the HLZ, they would be staged and ready to go, 5-10 minutes before you arrive. So whatever treatments needed to be done, you're like literally right there or very close by. Obviously, tactically important that you're not taking further casualties, just hanging out in the open, but in a protected spot close to the HLZ, 5-10 minutes before you arrive. Because often I see, we're, hundreds of meters away, and we're essentially running to where the bird is, and it's just kind of like race to the finish line,
Yeah. I'd say it's better for him to, if the environment permits it, like get staged a little early, and we'll say 2-3 minutes out, the patient's already packaged. You're kind of doing last minute checks, but you're also just getting your headspace right, because people always just lose their minds around spinning blades. So just get your headspace right, kind of rehearse like, all right, what do I need to say in this handover? Okay, cool. So ideally, the handover goes smoothly. Aircraft is on the ground for as little as possible, and patients en route to the hospital. That also goes with directing your helpers, already coming up with a plan, like, hey, you two guys take the feet, you two guys take the head. This patient's going to get loaded, head first or feet first, because nothing is worse than trying to hurt cats under rotor wash. So,
yeah, absolutely. So another kind of situation is, I've had like a prolonged care of this patient, and now we're doing more of a critical care type flight. Hopefully it doesn't go from that long-term care to like a rapid handover, but the same principles I would imagine apply if that was the case. I guess since there's so much documentation, there's so much that have happened over the last, 12, 24, 36, 48, 96 hours. I guess how does that change, I guess?
Yeah, so ideally, the more complex patient that is being handed off, we're doing more of a detailed report. So, but let's say in this scenario, the guy was getting worked on for the past 24 hours in, whatever safe house. If we can meet up actually in person where I come to you and we are actually doing a deliberate handoff of all the systems in play, assuming this guy he's intubated, he's vented, he's getting resuscitated, and he has nursing care done on him. Ideally, we have a longer handover face to face. So we're actually optimizing the guy before we throw him on an aircraft because, like I said, nothing gets easier in flight. So,
right. Is there such thing as a patient that's too unstable to transport?
I think it depends. I think yes, but most cases were in our realm, like on the battlefield. Usually that guy is hurt because the environment was non-permissive. So
he's going anyway.
He's gonna go anyway. We've already launched. We've already committed. We don't really have the time to kind of just shut down and kind of just work the scene like a civilian service would. We're kind of just we're committed. Okay, he's unstable, but okay, look, we gotta go. As opposed to a civilian setting where the aircraft might be shut down, patient unstable. Okay, let's work the scene a little bit. Let's get him to a good spot, and then let's fly him. Like, we don't really have that luxury in our domain.
Right. So, I mean, like oxygenation, like that's going to, I think, change, going from the ground to, air. Just altitude alone is going to, I think, affect that. I would imagine would affect that. Hemodynamically, though, at least what I've been told, even just liftoff can change hemodynamics. So I guess if I had multiple problems, would I target the hemodynamic aspect as a priority?
Yeah, if we're dealing with battlefield trauma patients, I would prioritize the hemodynamics of it. Personally, like, I've never seen anyone die of hypoxia on the battlefield. They usually die of other stuff first. So, and most rotary wing aren't flying high enough to really affect that. If we're already at altitude and we're trying to cross mountains, okay, sure, that's something to consider. But most of the situations we find ourselves in, I'm not as concerned with hypoxia. It's something to be aware of and be cued in, but if this guy sustained multiple gunshot wounds and he was a DCR candidate, I'm going to be a little more tuned in with the hemodynamics of the guy.
Okay, that makes absolute sense to me. So as far as me prepping the patient for some kind of evacuation, I guess what things can I do on the ground that would facilitate you taking over? Like, and I'm thinking like, organizing the lines, tubes, actually wrapping the patient, getting everything nice and tucked in. Is there, what other things, I guess?
Yeah, we're essentially just condensing an ICU staff and taking a critical patient and moving them with a military helicopter. So, kind of just going through the systems. Like, we'll start at vent, for example. Like, kind of the tube management and making sure the tube's actually secured. If the guy's vented, I'm going to bring my vent over. We're going to match settings. And so when we transition, it's not as significant for the patient. Ideally, we're kind of just doing as smooth of a transition as we can.
Okay.
Vent stuff, it's very... People seem to always chase these optimal, perfect settings, but what's perfect for the book may not be perfect for the patient. So it's what's important is making sure, like, what's been working for the guy. Maybe this patient specifically has been tolerating a little more hypercapnia, allowing for really not to induce any more lung trauma, because maybe his lungs are a little more sensitive. So to me, I kind of think of it as like, if I asked you to, like, watch my dogs for me for a few days, like, I wouldn't just tell you, cool, they eat this during this time and they drink during this time, bye. Like, I would tell you the stuff they're into. Like, yeah, he likes this toy, or he likes getting walked at this time. So there are kind of like nuances to each patient. So really kind of honing in on the specifics of each patient. Like, yeah, he is just not tolerating high tidal volumes. So this is where we're sitting at, is good information to transfer. So just being able to, like, hone in on those subtle changes.
Yeah. And I would imagine like narcotics are probably the same. Like, he tolerates fentanyl better than ketamine, or, you know, et cetera.
Yeah, exactly. Like, something that's awesome to have. Yeah, obviously, like, the drug sequencing and timings of what you gave him, but also, like, what is his, mentation from these narcotics that you've been giving him? Is he tolerating them? Is this dosage keeping him from biting the tube and bucking the vent? So it's good. It's like, it's tell me what you did and tell me if it's working, and then cool, I can kind of continue that then.
Okay. Prepping gear, like, when you're, obviously you have like an SOP when you're transporting, but say I'm going maybe from ground and we're probably maybe self-evacuating or something like that. How would you prepare your gear for that type of transport? So when I'm thinking about it is, okay, the patient's been criked. All right, I'm bringing another tube. I'm making sure my suction is good. I probably have some kind of backup, and I make sure I have, I make sure all the equipment, in that vein works. He's got a chest tube. I'll have another chest tube. I have the Heimlich valve, maybe an extra Heimlich valve, a Pleurovac if we can, and I have backups. I have backups to backups, and I make sure, hemorrhage control stuff. I have more narcotics, et cetera, et cetera. I guess, how do you think about that, or does that work?
Yeah, I bring the equipment as if the patient was completely untreated, and that gives me a good enough buffer to work with. Now there's redundancies already built in. If in some weird circumstance where no treatments have been done, it's like, okay, well, I have enough to try to work March and then some and stabilize the guy. But ideally, the guy on the ground did a good job, and now I have redundancies of, cool, I have extra chest tubes. I have extra ET tubes if they need to get switched out, IV tubes and such. Certain things are going to have to get switched out anyway. Like we carry an inline suction, kind of like they do in the ICU. I have proprietary tubing for my drug pumps. Something I do with my vent, and you can do with the Sparrow, is the trigger sensitivity. Sometimes turbulence and vibrations can set off a mechanical breath. So turning that sensitivity all the way down, so you're not just artificially inducing a breath. While the machine thinks the patient's taking a breath, really it's the oscillations triggering it. So, cable and IV line management, really any lines, having that organized goes a long way. Because the worst thing you can do in a dark, loud, cold place is to induce even more confusion. So have those lines already secured, have it kind of organized in a way where it makes sense and where it doesn't get in the way of things or could get caught on things.
Okay. Do you label your lines? Like, hey, this is ketamine. There's a ketamine drip. This is an antibiotic drip. This is, whatever.
I like to. Yeah, once they're on like a dedicated drip and I know they're going to be on it for a while, then I'll mark it in a way where I can't mix them up. Yeah. And it just depends on the transport too. Like sometimes bumps might be enough just to get me to the next place, and sometimes I might get the drug pump out because I need something to kind of to go for the duration of the flight because I need to preserve bandwidth for other stuff. Like, okay, let's continue working this chest problem or this air problem. So it's ideal. I have a dial-a-flow just in case, but it's not that accurate, and counting drips in an aircraft isn't the greatest thing. It's like trying to count drips in a moving car driving over rocks. Like, it just doesn't work great. So, especially once you start kind of messing around with pressors, like that's something you really want to be accurate with. Ketamine, I could get in the ballpark with drips and still be within like a threshold of safety. Pressors, I want that to be as accurate as possible because there is more risk associated with that.
Yeah, absolutely. Speaking of narcotics, like how much, at least obviously every trip is going to be different, but generally anyway, do you see the patient's pain requirements go up during transport or essentially stay the same as they are on the ground?
They generally stay the same.
Okay.
Times where I've seen it maybe go up a little, maybe like a broken back or like a neck injury. Sometimes turbulence can kind of make that worse, but generally they stay the same. And hopefully we've kind of gotten to a good measure of, okay, he needs this much for pain control before we got on the bird. So,
okay. So if he at least has pain control on the ground, he's probably in a good spot for transport.
Yeah, I'd say it's possible, but generally, to me, I've seen it just stay the same.
Okay, perfect. If you do bumps en route, do you like doing like short-acting narcotics, or do you push a fair amount of like hydromorphone or morphine?
Yeah, it depends. If the guy's sitting in a good place and his biggest problem is his pain, okay, let me get something long acting. And especially if I have multiple patients, let me get something long acting on this guy who pain is his biggest problem. So I can kind of focus my resources and bandwidth on a more severe guy. If it's my only guy and he's not really urgent, okay, I could go with bumps of fentanyl and see how he accepts that. So I like starting with short acting first and knowing how that sticks. Dilaudid's nice, but it is sticky. It does last a while. So I want to know how compliant this guy is with drug admin.
Yeah, no, makes absolute sense. During transport, like you're monitoring, so do you depend a lot on the electrical type monitoring, the automatic BP cuffs, and et cetera, or how does that environment affect your ability to like just manually get vitals?
Yeah, it's not as bad as I think the schoolhouse makes it. You can still feel a pulse in flight. Maybe if you're flying through weather and it's just constantly vibrating, okay, fine. But generally, yeah, you can still get a pulse in flight. The monitors help a lot because you're deprived of some of your senses. So having a good blood pressure from your monitor helps. The end titles are especially helpful. It's a little harder to feel and count breaths as you got wind in your face. So a technique is taking like a BVM mask, taking an EMA, and just placing it on the dude's face, understanding that you're not going to have an accurate end title, but you can get a ballpark count of where he sits and a decent count of his respirations.
Okay. And I mean, if his end title is completely out of whack, maybe he needs an actual airway.
Right. Yeah. So it's all contextual. All of these tools that you have, they don't replace your decision making. They just support it. So, yeah, exactly with that thought. Like if you take an end title and BVM and stick it on his face and his end title's out of whack, it's like, okay, we'll look at your patient first. Like, what's going on? Is his injury pattern, does that correlate with, okay, maybe this guy is going to lose his airway and I need to take it? Or maybe he's looking at me, he's perfectly fine, and it's probably the environment just messing with my numbers. So everything is contextual and should be used to support your, clinical acumen, but these devices and tools, they shouldn't be making them for you.
Okay. Is there anything else that we need to talk about when it comes to like preparing a patient for transport or care of a patient during transport?
Yeah. I don't expect iStats from guys. But
Good.
if you, yeah, it's one of those, like, if you have it, it's great, but I'm not overly concerned. It's nice, yeah, if you trend it, but if you just tell me I've been continuously putting blood in this guy, I'm like, okay, well, he's probably still a DCR patient. He probably still needs surgery. There are other forms of things to trend, like that are high yield also, like neuro checks, actually trending your vitals, knowing, is this guy doing better? Is he doing worse? As you're trending those vitals, those last minute nursing checks, like, is tube placement good? Did it shift? When's the last time this guy's mouth was cleaned? Does he have compression socks for DVT prophylaxis? I don't count on most guys to have those calf compression machines, but does he need to be positioned a certain way? And really just the contamination stuff that we don't really account for most of the time in training. Like, did this guy just soil himself? So do you have one of your buddies helping you with the bio and contamination stuff? Are there a bunch of Chuck's pads laying around? So it's ideally, hopefully we're like cleaning this guy before he gets on the aircraft. But that's really the overarching theme here. Like, optimize your patient for transports. Get him as stable as possible and just set the provider in flight up for success. So, keeping lines secured, making sure nothing's kinked, making sure he's in a good place, whether it's narc administration or fluid resuscitation. And something to consider too, depending on what system you hand off to in a military setting, you're handing off to a Roll 2, but sometimes you're handing off to base level medic or 68 whiskey. You're not necessarily handing down because you're handing off to a system, but also like know who you're working with. And this really goes into planning and engaging with those assets ahead of time. Because that 5 to 10 minute truck ride to the actual hospital from the airfield, I consider that also optimizing him for that transport. So I don't want to just throw an unstable guy, if I don't have to, into a truck without me being there. So hopefully we've stabilized them as much as we can for that truck ride to the hospital. If not, I'll just go with them and really just know who you're working with. Know the capabilities of each segment all the way back to the surgical site and then some. So you're not getting caught off guard by things that will kind of bite you in the ankle. Like, hey, this guy needs to be managed on event, and the provider on the truck has never seen an event or doesn't know how to manage event. And like, all right, well, that's kind of a problem. So,
right. Awesome. Well, thank you, Rich. I really appreciate it.
Yeah, of course. Thanks for having me.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast. Out.